with community groups, and then we can. Good afternoon, everyone. Welcome to the weekly webinar. We're so excited to have you here. Welcome. Please make sure that you are muted while our presenters are sharing today, and use the chat feature when you have questions. And I just have a feeling you might have some questions. So feel free to use that. If you need the closed captioning feature, it's at the bottom of your screen, a button that says CC for show captions. Feel free to engage that as needed. Those are all the announcements. And so I'm very eager to shift over to introducing some names that I think are familiar to everyone on the call today. We have presenting with us today, Dr. Jeffrey Burns and Dr. Russell Swerdlow. Dr. Swerdlow is the director of the KU ADRC, and Dr. Burns is the co-director of the ADRC. Dr. Swerdlow is an alumnus of New York University, where he got his undergraduate and medical degrees. And his specialty area is brain energy metabolism. You may have heard him referred to as Mito Man. And Dr. Burns is the co-director of the ADRC and started KU Med Center's clinical research program 21 years ago now in 2004. And he is an alumnus of Notre Dame, KU Medical Center, University of Virginia, and Washington University. So I don't have to convince anybody that we have some real expertise with us today. So with that, Dr. Burns, I know you're going to kick it off. One more thing, I did refer to Dr. Burns in our direct chat just before we started, and Dr. Swerdlow as number 15 and number 87. So take it away. I'll let you decide who's 15 and who's 87.
I got my Chiefs gear on. So thank you, Kelly. I just talked to Russ, so I know he's coming. If he's not here, I don't see him, but welcome. It's great to see everybody, and we got a great turnout today. So here's our plan: is to no slides, open-ended. There's Russ. Kind of do the open-ended discussion. So we'll talk for maybe 15 minutes and kind of give an overview of biomarkers and give some perspective on that. It's a big time in our field with the introduction of these new diagnostics. So really exciting. So we'll give a kind of an overview on that and kind of talk about some of the things we're doing. And then we can open it up for questions. So, and the questions, feel free, please put them in now. Type as we're talking. You can go down to the chat down there at the bottom, right there. Click chat, and you can type it in, and we'll try to address it in the second half, the second 15 minutes. So, my office is a disaster, huh? It's actually really organized, and we're doing it. We're putting up a nice TV, big computer screen for meetings back here, but everything's really organized in my world. So. But okay, so
yes, your room's a mess.
That's how I like it. It is a mess. So, Russ, so I'll start. I'm going to give kind of an overview of biomarkers. But Russ, any comments before we get started?
No, it sounds good. Sorry, I'm late. It's just someone was having a meltdown about the Chiefs game, and had to ask about the Eagles front line. So. But now let's talk about biomarkers.
Okay. So, great. All right. So yeah, biomarkers. We call them biomarkers. What does that mean? It's short for biological markers. And these are measures that are sort of invented to detect the presence of something biological that we want to detect. And in the world of Alzheimer's, we are most interested in things that are occurring in the brain. And the big things that we've been looking at for 100+ years are amyloid plaques and something called neurofibrillary tangles, which Dr. Alzheimer described in about 1900. And we've been looking at ever since. And so that's sort of what the field considers the hallmark pathology of Alzheimer's disease, amyloid plaques and tangles. Russ, on the other hand, and our center considers maybe mitochondrial dysfunction, a different measure, as the hallmark of Alzheimer's, but we're working on that, trying to prove that. But But the convention is amyloid plaques and neurofibrillary tangles are used to define Alzheimer's disease. And so we're trying to detect those when to make a diagnosis through biomarkers. We've been doing it for a while, for, I don't know, many years, using tests in different ways. And I'll just give you an example of some different ways. One of the main ones is doing a lumbar puncture where we collect spinal fluid that surrounds the brain, and we can test that spinal fluid for amyloid and tau measures, or proteins, and get a sense for is there amyloid plaque in the brain or neurofibrillary tangles in the brain. That's been ongoing for decades, as a way to detect these changes. And it's kind of interesting when you would expect both of those to be high if there's amyloid and tangles in the brain. And what happens is the tau measure actually goes up if there's tangles in the brain. The amyloid measure in the spinal fluid actually goes down if there's amyloid in the brain. And so surprisingly, so low amyloid is what we're looking for in the spinal fluid to detect the presence of amyloid in the brain. But that's a technique we've been using for a long time. It's kind of our gold standard. In the last 15 years or so, maybe first scan was 20 years ago. The methods to use imaging to detect amyloid in the brain in living people was developed, and now tangles in the brain. And the way this works is we use PET scans. We can inject a label that sticks to amyloid or sticks to the tangles and emits a signal that the PET scan can pick up. And so this has been developed and is now in sort of broad use in the research arena, and in limited but much broader use now that Medicare is paying for some of these things. We can do amyloid PET scans in the clinic. So that's another example of a way we detect, biomarker. We use biomarkers to detect the presence of these changes in the brain. So spinal fluid and then PET scans. There's other skin biopsies, muscle biopsies, things like that we can do, not for amyloid and tau, but lots of different ways to measure it. Now, the holy grail of biomarkers has always been we want and need a simple blood test that gives us the information to understand if, amyloid or tau is present in the brain. And that this has been, part of the field for as long as I've been working in it, which is about 25 years almost. And then not until recently have we gotten to where we've got pretty accurate, pretty precise measures now that we can use to detect these amyloid plaques and tangles. So this is, these are sort of, we think, game changers. They're not changing the game quite yet. We got a lot of work to do before they do, but the potential to give tools to, us, memory specialists and researchers, but also primary care, give these kind of tools to give doctors the ability to get a good measure that reflects the likelihood that the Alzheimer's changes of amyloid plaques and tangles are present in the brain is a big deal. So now how we use that is a big effort now, and how we get that out to all the doctors is a huge effort that we'll get into. And we have two projects that we can talk about in a minute. This something we call the Davos Alzheimer's Collaborative, who's sponsoring us to help figure out how do we get health systems and primary care docs using these tests effectively. And then we're working on a collaboration with BYU, who has really next generation tools where it's going to be important to compare those tools to what we're doing today, but potentially really change the game for how we're measuring these things in 5 to 10 years. So before we get into those, actually, Russ, you want to add anything to sort of
Yeah. So, that's a good overview of these biomarkers and what they do. And, a point that I've heard you made in the past is just yesterday, if you want to consider yesterday the past, is what these drugs or these tests tell us if we have are we likely to have plaques in our brain. And so then the question comes up, what does it mean to have plaques in the brain? Does that mean you have Alzheimer's, or does that mean you have a brain that's getting older, or does it mean you you have memory problems, or does it mean you're going to get memory problems? And that's a whole much more complicated answer. And that's a question that, guys like you and I are sort of, it's a discussion we're having all the time in the field about what it means to have plaques. Does it mean you have Alzheimer's disease, or do you need more? Do you need plaques and tangles? Do you need plaques and tangles and memory issues? It's a good question. I'm not. We don't all agree on this.
No, we don't. And this is, yeah. So Russ is saying a lot of different things that we could spend the whole hour talking about.
Hey, it's like a podcast here.
Yeah. But so I want to just dive in on make one comment you made at the start of your comments, which is, how do we use these? They're tools. They're really not an Alzheimer's test. Like you run the test and it tells us, yes, you have Alzheimer's. It doesn't tell us, it tells us, yes, may have very high likelihood that you have amyloid in your brain. And so, Russ, you were saying, yeah, how do we interpret these? And we have to interpret. So it's really important to know these are tools that need to be interpreted in context. In the context for a clinician to know the history and what's going on with the patient, what kind of changes, and then interpret the test in that context. And so, Russ, you're making that point in the first half of your comments, and the second half, you're talking about what is what is Alzheimer's? How do we even define that in our field? And he's alluding to something we could spend days talking about, but our field is really wrestling with what is Alzheimer's? How do we define it? Should we define it simply by the presence of amyloid, or should we define it by the presence of memory changes, with amyloid, due to amyloid is how people think about it. So, and and let me just give an example of why this is so important. If we took 100 people, age 70 to 75, and we tested them for amyloid, about 25 of them would have amyloid in their brain, but not have any memory problems. Okay, so do we want to call those individuals Alzheimer's, as having Alzheimer's? Of those 25, how many will develop the memory problems? We don't really know, but it's not as many as you'd think. Some of the best data we have right now is about 6 years later, maybe 10 to 15% have Alzheimer's, have dementia. That's not as many as you'd think. So I don't really want to call that group or tell that person that they have Alzheimer's, because they have a low but real risk of developing Alzheimer's. But just on the basis of amyloid present in the brain alone, I don't think we want to call that person or tell them they have Alzheimer's.
Well,
There are people in our field who are saying this is Alzheimer's because there's amyloid there. And
Jeff, just to make a podcast out of this, so you did the Apex trial, about 10 years ago, in which you did a lot of amyloid PET scanning of people without memory issues to try and find people who had plaques but normal memory.
right.
And and you found about if I remember right, about 100, 200 such people.
About 100.
About 100 people. So out of those 100 people, 10 years later, how many of them are still cognitively normal?
Yeah, well, I bet there's some on here right now who are doing great. So we didn't set that study up to actually answer that question. Unfortunately, we couldn't at the time, but it's probably 75, 80% are still doing well. So that's exactly it right there is, do we want to tell those people they have Alzheimer's? We don't, but there's people in our field who do.
Yeah. Well, that's kind of there are some angles of the field that would say if you have plaques, you have Alzheimer's, and it doesn't matter if you have a normal memory or a shoddy memory, or if you're even ever going to have a shoddy memory. And well, I don't know. I'd hate to, if I had a positive test, I would prefer not to be told today that I had Alzheimer's.
Yeah. And I'll just say from the angle of the people who are arguing that we should call that Alzheimer's, they're thinking ahead about drugs that might be effective in reducing that individual's risk, even if it's small. And so
Well, I suppose that would, well, that might help answer, put some perspective on the question. If getting rid of the plaques absolutely meant that you weren't going to develop memory problems,
right.
then, you know, that might support defining the disease as the presence of plaques. But if you remove the plaques and people still develop memory problems later on down the line, I think that would argue pretty persuasively that uh, you know plaques probably shouldn't be the sole criteria.
Yep. So we see eye to eye on this, Russ and I do for sure. But the good news is though, the field and us here at KU, we are testing this idea in a big trial called the AHEAD study. Some of you may be in that, where you're cognitively normal, no issues with memory, but there's amyloid present. And we're testing one of the approved drugs, Leqembi, to see for that individual, if we treat him for 4 years, does that reduce the risk of developing dementia? Or clinical signs of Alzheimer's disease. And if it does, then I bet we'll be. I'd rather call it high amyloid in the brain than not Alzheimer's and be a little more precise. But we may lose that battle and end up having to call it sort of preclinical Alzheimer's disease. But so we're getting a little sidetracked, maybe a little sidetracked.
Well, a little sidetrack, but it's kind of fun. I think people are enjoying it. This they'll be interested to hear about this one conversation at one of our national meetings in which someone brought up the question of what are we going to call people that we said had Alzheimer's and then we removed their plaques and they still have memory problems. Do we have to change the name of what we're calling them? Could we have cured their Alzheimer's and left them with some other condition that we now have to come up with a name for, like post-plaque memory problems?
Yeah. So our field is wrestling with semantics. And I don't think arguments over semantics are all that useful, but it is important when we're developing models, for how to conceptualize and models for how to treat, something.
Well, it looks like these questions are
we got a lot of
flying
questions.
fast and furious. So,
Russ, why don't you read through those? I'm going to just talk really quick, and then we'll come to Russ for an answer for some of these questions. But I haven't read them, but I see them coming in. But okay, so we have two sort of biomarker related projects, and one, the Davos Alzheimer's Collaborative supported project of ours, where there's 8 sites around the world. We were kind of handpicked. We competed, and then we're handpicked to be a part of this program. And what we're doing is we are working to try to develop a sort of blueprint for how does a health system, not just a memory clinic like Russ and I, how does a health system use these new blood measures? They're here, and they're here to stay. And it's not as simple as just turn them on in the health system's, order set and the lab. You just don't turn it on until the primary care docs start using it, or even the memory clinic docs start using it. So we've been working really hard for about a year to develop an educational program, a set of tools built into our system, our electronic medical record, and then to get the blood biomarker lab. Dr. Jill Morris is leading that, get that lab certified, validated, and ready to go. And so the idea is to get primary care docs using those tools that we're creating in the blood measure to get better at making the diagnosis of Alzheimer's disease in their clinic. And then we're actually partnering better with them and have developed new ways for our memory clinic to work with them in primary care. And to give you an example, 2 years ago, we'd say, or actually a month ago, we say, call our memory clinic and get in line at the memory clinic. That's what every memory clinic in America does that. Every memory clinic in America also has a 9-month line, 6 to 12-month line. So about 9 months of waiting to get into a memory clinic, which is not a great model. So we're working on new models for how do we make our memory clinic more effective and more able to meet the needs of the increasing number of people with it. We're doing that in a couple of different ways: e-consults, electronic consults, and then two different types of clinic within our clinic that will sort of steer people into to get more efficient. So that's just a really quick overview of the Davos project. And then the other is this BYU project, where BYU has a measure that's a biomarker that's really interesting, where they are looking specifically at fragments of DNA that they can detect in the blood. The patient's own DNA floating around in the blood, and they can detect if that DNA what cell it's coming from. Is it coming from the brain? Is it coming from certain parts of the brain? Meaning, are those cells breaking down? Are we seeing neurodegeneration in those cells? And if they can detect higher levels of DNA from certain cells, then we can say, all right, there's a neurodegenerative process going on, and use that for supporting a diagnosis. So it's a really cool sort of next generation biomarker idea. And they're using us because we followed 1,000+ people for the last 14 years, and we have blood and other measures on them, including probably many of you who are part of our cohort. And they're going to use that data and those samples to test their ideas around this new biomarker. So it's a cool time. So that's the sort of overview of those two projects. Russ, you got any?
So I was scrolling through these questions here, and there's so many great ones. So I'm I'm gonna maybe interview Jeff and make a few comments of my own here for some of these questions. And I'm going to take them out of order. So I apologize. I'm going to take them out of order because some of them follow directly from things that Jeff and I have been discussing. And so one question that came up, and it ties through a couple of questions, is about, hey, I'm in my 50s. I'm going to see my primary care doctor. Should I be getting one of these tests? If so, which test should I be getting? And is this the future? Or is this research, or is this clinical stuff? And well, I'll just say, we're talking about, these are tests that regular doctors can order. Now the question is, should you get one if you don't have a memory problem? That's something our field has been wrestling with. And well, Jeff, why don't you take it from there?
Okay. So should somebody who does not have clear memory changes get one of these tests? And I think the answer today is pretty clear right now, that it's no. Unless you're in the research arena and doing it with a research group, but not with your doctor. Now, in 2 to 5 years, that might be different, but today, if you don't have memory changes, it doesn't tell us a whole lot that we can act on. And so I would say no. And that's what we're telling our primary care docs.
Yeah. So, Jeff, I've had a couple of patients that I've seen in clinic where they came to me because they said, "Hey, I'm still working. I'm doing well. I don't have memory complaints, but the other day I left the department store, and I couldn't remember where I parked my car. And I saw my primary care doc a couple of weeks later for my annual checkup, and I said, "Hey, the other day I couldn't find my car in a parking lot," and the doc said, "Oh, hey, let's do a blood test." And I did this blood test, and it cost me like $1,000. And now they're sending me to you because they say I have Alzheimer's disease. Uh,
Yeah.
have you had any of those?
Oh yeah. And this is why we need to be careful, and we got to do it in the right context, these tests, because this is back to that what we were talking about, where these individuals who have amyloid, we know 25% of people over the age of 65 have amyloid in their brain, but how important is it for us to know that? How high a risk is that? It's not as high as we would think, and we don't have drugs yet to treat it, so it's just not worth doing it unless there's memory changes. It's important. The presence of amyloid in the brain is really important when somebody has memory change, for a couple reasons. One, it tells us that the likelihood of it being Alzheimer's is really, really, really high. In fact, our definition meets our definition. But two, we have the new drugs that go after amyloid, and especially in early patients with early memory changes. we have anti-amyloid drugs that can pull amyloid from the brain and slow things down. So it's important from a therapeutic perspective to understand if amyloid's present in the brain. So, but that's it. I mean, Russ, it's we create more angst than action if we're using these tests in the wrong patients.
Yeah. So there was one question that builds off of this one. Actually, two questions. One was, what's the best test to get? And I'll just quickly say that it looks like the best test is going to be, or currently is, a test for phosphorylation at site 217 of the tau protein, or what we call p-tau 217. So that if you have blood drawn and your p-tau 217 is above a certain cutoff level, there's about a 80 to 90% chance that you have plaques. So it helps predict plaques. So is that helpful? Well, I mean, I can probably do a little bit better than that just by spending an hour with a patient. But it is, if it's a good way to try and confirm or refute my clinical impression. Yeah, the bottom line is we in the clinic, I'm not sure it would be a good idea to get one of these tests if you don't have a memory problem, if you're just kind of curious in screening, where you may stand. Now, this leads to another question that's on this list, which is, what about ApoE testing? So this ApoE testing is kind of a similar question. This is a biomarker test that we've been doing now for over 25 years. That kind of predicts whether someone is on their way to getting Alzheimer's. I might think that maybe one of these blood tests for amyloid, or the p-tau tests I mentioned, that might be akin to how far are you from the cliff. And the ApoE test, which is looking at your genetic predisposition for the disease, that might be more akin to telling you how fast you are heading towards the cliff. And we've dealt with this question too: should people without memory problems do their ApoE genotyping? And it's kind of a funny story. Jeff and I have been back and forth on this question of ApoE testing for quite some time. And so those of us who are big risk takers, and bold, and may sort of enjoy knowing what their status is, and some of us who aren't big risk takers, or may not want to know. And you guys can all try and guess who's who.
Yeah. It's true. And there's, you have to think personality plays a role in, testing, right? Especially in this group, if you don't have memory problems, ApoE, and then even amyloid. I know my ApoE status, and
Oh, you gave it away. You're the bold one.
I'm going to give it away. But I do know that probably because of this research we've done, that study that Russ was talking about that we did about 10 years ago, the APEX study, we learned that probably 20 to 30% of people that were interested in the research decided, no way, I don't want to know my amyloid status. No way, don't tell me, I don't want to talk about it. So, and then there's 20 to 30% who are like, it is what it is. So yeah, of course I want to know. And then there's some in the middle who are like, yeah, I'd like to know. And then I'd probably, it'll bother me, but it'll cause me to exercise more or eat better, and I'll use it as motivation. So, yeah, so we got to be really careful.
That was another question too about, how do lifestyle choices figure into all of this? So, does knowing your situation, Jeff, or your biomarkers, your ApoE and all that, does that affect your decision to eat well or exercise? Or
well, I didn't have the high risk gene, so I don't know what I would think. It probably would have. So, but I try to exercise, but I could do better for sure.
Well, I remember you saying before you found out, you said, "Yeah, if I have the high risk, I'll just exercise harder."
Yeah. I probably would weigh 10 pounds less if I had the E4 gene. a little extra motivation. So the high risk gene, I'm seeing that come in. It's ApoE, and then it's the E4 allele. So there's three choices. But if you have it, if you're an E4 carrier, is what we talk about, then you're at higher risk. 25% of the population has an E4. So I mean, it's common. It doesn't mean you're destined for it, but it means you're at higher risk. So it's a risk gene, not a definitive sort of deterministic gene that says you're going to get it. So what else? Oh, well, we're at time. We want to
Yeah,
do.
this is like boy, this went fast. This kind of combination podcast town hall. We should probably do this again.
Okay, real quick. I saw two questions in here. We'll reiterate. We've kind of answered the, hopefully I'll be redundant probably, but yes, people who are normal can have amyloid in their brain, have amyloid plaques. They can have a lot of them and they can live without developing dementia or Alzheimer's disease. We need to get better in terms of understanding, what the percent risk is over a time period. But it's 6 years later, the minority, less than 50% have memory problems who have amyloid without memory problems. And then somebody asked about what about the drugs for those individuals? And we're testing those drugs to see if those individuals who have elevated amyloid without memory problems, if we treat them for 4 years, remove the amyloid, does that reduce their risk of developing dementia? We don't know yet. But that is a huge question in the field that the field's tackling right now. And then I see one more. Our tool is available now for primary care docs to use these tests. The answer, and how far in the future is this? It's probably a month or two here because of the Davos Alzheimer's Collaborative. We've been working for a year to turn these tools on in our system, and it's really challenging. But we think we're 1 to 2 months away from having these, and they will be adopted kind of slowly across primary care. So your primary care doc may not know about them and may not use them yet. We're going to train all the primary care docs and the memory clinic docs to use these things in 2025. We'll say that. All right, shall we wrap it up? We're 2 minutes over, but thank you everyone for tuning in. And yeah, this can be watched again somewhere. Kelly put it in there.
Yes.
And Kelly, I guess we'll turn it back to you.
Thank you. Thank you, Dr. Burns and Dr. Swerdlow. I feel like my typing skills really improved as I was trying to catch up with everybody's comments and questions. So yes, we have recorded today's presentation. It takes about an hour for me to get it edited and uploaded. So check back later tonight on our YouTube channel or on our website, and certainly by tomorrow. And in our next issue of the My Alliance newsletter, which you will get Monday morning at 7 o'clock. So by then, for sure, this will be available. I saved the chat, so we had so many great comments and questions, and I will say, Dr. Burns and Dr. Swerdlow, maybe I can send you a compilation of the questions, and as you have time and availability, maybe you'd be willing to give us some answers to those.
Would the Medicare likely to cover those tests?
That question.
Yes, insurance.
Go ahead,
so yeah, insurance is likely to cover these tests. Here, because of the Davos Alzheimer's Collaborative, for about a year, we're going to cover the tests. We're going to pay for them, so they'll be free. The field, Medicare, insurance companies, it takes time for them to work all this out. It's being worked out, but these tests should be pretty routine to get in the right patients, in the near future. So.
Perfect.
Okay.
Right. I can see this, the Jeff and Russ podcast. Questions answered, answers questioned.
I love it. You heard it here first. You'll be the first to know when we make that happen. Thank you, everyone.
All right, thanks.
Dr. Swerdlow. And we'll see you all next week, and you'll find out what next week's topic is in the newsletter next week. All right. Thanks, everyone. Take care.
Bye.